Good day, and welcome to the CAP webinar entitled The Final 2026 Medicare Policy and Payment Changes for Pathologists. During the next hour, we will discuss the final regulations and policies for the Medicare Physician Fee Schedule and Quality Payment Program that will be used to reimburse pathology services in 2026. Before we get started, I would like to review a couple of technical details about today's presentation and introduce our presenters. Please type in your questions during the presentation. There will be time at the end of the presentation for our panelists to address them. We will select questions that are a representative sample of those submitted during our limited time here today. An archive recording of the webinar will be available later next week. The CAP will have a link to this presentation along with a PDF of the slide deck in the webinar section of the cap.org website. Let me now take a moment to review our agenda and introduce our presenters. Next slide, please. Your moderator for today's webinar is Pamela Yazdani. Ms. Yazdani is the Senior Director of Economic and Regulatory Affairs in the CAP's Division of Advocacy, located at the CAP's Washington, D.C. office. Next slide, please. Our first presenter is Dr. A. Joe Saad, Chair of the CAP's Council on Government and Professional Affairs. Dr. Saad is also a member of the CAP Board of Governors, Chief of Pathology for the Methodist Health System in Dallas, and Adjunct Associate Professor of Pathology at the University of Texas Southwestern Medical Center. Next slide, please. Our second presenter is Dr. Ronald McLawhon, who is the chair of the CAP's Economic Affairs Committee and a member of the Council on Government and Professional Affairs. Dr. McLawhon is also professor and vice chair of pathology, head of the Division of Laboratory and Genomic Medicine, and director of the clinical laboratories at University of California, San Diego, and UC San Diego Health. Next slide, please. And our final presenter is Dr. Gregary Bocsi. Dr. Bocsi is the chair of the CAP's Value-Based Programs and Healthcare Policy Committee. Dr. Bocsi is an associate professor of pathology at the University of Colorado School of Medicine. And now it is my pleasure to turn the presentation over to Dr. Saad. Next slide, please.
Oh, well, thank you very much, Ms. Yazdani, and good day to everyone. During today's informative webinar, we're going to briefly review the CAP's policy and advocacy agenda with regards to Medicare payment. Then we will thoroughly review the changes to the final 2026 Physician's Fee Schedule, the impact on the codes and outlook for 2026. We'll review the final 2026 Quality Payment Program policy. Then I will urge everyone to take action before we go to questions. Next slide, please. The CAP, AMA, and other physician specialties are pushing hard for Congress to fix Medicare cuts once and for all. PAMA and MACRA have not delivered on the promises made a decade ago. Over the past 10 years, payments to pathologists have decreased by approximately 9%, while our practice expenses continue to increase by about 24% over 10 years. The gap between payment to pathologists versus practice costs continues to worsen in the 2026 final fee schedule. This is largely due to a lack of an inflationary update to the physician fee schedule. According to the American Medical Association, Medicare physician pay fell 26% between 2001 and 2023 because physicians do not get yearly inflationary updates. Unlike other entities paid under Medicare, particularly Part A, such as hospitals, ambulatory surgery centers, nursing homes, they get an annual update, but physicians paid on Part B do not get this update. Next slide, please. The final 2026 Medicare Physician Fee Schedule and Quality Payment Program regulations were released on October 31 of this year. That evening, CAP members received a special advocacy update with an initial analysis of this regulation. The CAP is going to continue to engage with the Centers for Medicare and Medicaid Services and Congress on behalf of pathologists. The final regulations will be implemented on January 1, 2026. Next slide, please. Here you can see the growing gap between Medicare pay and inflation. We've reached a delta of approximately 33%, as you can see on the right-hand side of this graph. For 2026, the average pathology Medicare payments are forecast to increase by 0.34%. Again, physician practice costs are up 24% since 2017. Congress must stabilize the Medicare payment with an annual PFS inflationary adjustment. This was a featured ask during our last April's Pathologist Leadership Summit and Day on the Hill, and we will continue to push hard for a final and permanent fix to this growing gap and tie it to an inflationary update. And with that, I'm going to turn the presentation over to Dr. McLawhon. Thank you.
Thank you, Dr. Saad. Could I have the next slide, please? So there are many complex variables that have impacted the Medicare final rule and physician fee schedule for 2026. I hope to be able to distill this information for you over a series of the next slides. So first, yes, there's a non-qualifying APM conversion factor increase that was about 3.3% for 2026 relative to the 2025 fee schedule. But this is a temporary increase and does not reflect the true impact on pathology. The bulk of this increase is driven by the One Big Beautiful Bill Act, which will increase overall physician spending by 2.5% for 1 year. Policies announced in the release will impact physicians differently and will depend on a variety of other factors, including case mix and practice type. However, on average, pathology will only see 0.34% increase in 2026. On the other hand, independent laboratories will see a 1.14% increase. I'll get into the reasons why a diminished increase in the subsequent slides. Next slide. Okay. Starting in 2026, CMS is proposing to split the conversion factor on whether a physician is a qualifying participant in an advanced alternative payment model, or an APM. As required under MACRA, the Medicare Access and CHIP Reauthorization Act of 2015, those physicians who are qualifying participants in APM will receive a slightly higher conversion factor update and thus slightly higher Medicare payments in 2026 compared to physicians who are non-qualifying participants. And the majority of our pathologists are not in APMs. So both conversion factors are adjusted by a positive budget neutrality adjustment, largely resulting from the efficiency adjustment policy that I'll discuss in the next slide. The proposed conversion factors are, for qualifying APM conversion factor, $33.5675, and non-qualifying APM conversion factor is 33.4009. Next slide. So the efficiency adjustment, and this is a major factor that's impacting pathology and other non-time-based specialties. CMS finalized the efficiency factor adjustment based on their concern that productivity efficiencies are not accounted for in current physician work RVUs that are determined by the RVRVS Update Committee for non-time-based services. CMS noted that diagnostic tests and other non-time-based services should become more efficient as they become more common. Professionals gain more experience, technology is improved, and other operational improvements are implemented. As a result, CMS, the efficiency factor will decrease the work RVUs and intra-service physician time for non-time-based physicians by 2.5%. This adjustment is arbitrary and based on the sum of the Medicare Economic Index, or MEI, productivity adjustment over the past 5 years, which has been one of the highest inflationary periods in recent history. Additional concern, CMS indicated that the initial approach is conservative, and they may consider making updates to PE inputs such as reducing clinical labor times. Further, they also stated within the final rule that further efficiency adjustments are also anticipated to occur every 3 years. Following advocacy to ensure consistency in the application of the efficiency adjustment, CMS correctly classified our pathology clinical consultations as time-based services and are exempted from the final policy as they mirror what's going on with the evaluation and management services. Those are time-based services. Therefore, the work RVUs for CPT codes 80503, 80504, 80505, and 80506 will remain unchanged and will not decrease by 2.5% in 2026. CAP will still strongly oppose the overall finalization of the efficiency adjustment and is engaging CMS, congressional leaders, the AMA, and CAP members through grassroots efforts to advocate for the reversal of this payment cut. Again, this is largely affecting those who are not doing time-based services, such as the primary care folks who use evaluation and management codes. So can we have a next slide, please? So how does this really look to the overall impact for pathology? You can see efficiency adjustment will apply across the full spectrum of pathology services, including key CPT codes such as our 88305, surgical pathology codes, our special stains 88312, immunochemistry 88341. As an example, if you look at the 88305, which is the largest service that pathologists provide, it's anticipated that the RVUs will decrease from 0.75 to 0.73%. So CMS is effectively reducing what was a RUC valued service. Both global and professional components, the -26 modifiers, will be impacted by the policy. Again, those highlighted in yellow, the pathology clinical consultation codes, are exempt from the efficiency adjustment. As noted, the work RVUs for 80503 and 80505 will remain unchanged for 2026. Could I have the next slide, please? Okay, practice expense, and particularly it's the indirect practice expense. So hospital-based physicians are most at risk for the CMS policy to reduce indirect practice expense reimbursement to services provided in a facility setting. Finalizing its policy to reduce facility practice expense RVU, CMS acknowledged that services billed under the -26 modifier will be exempt from the site of service payment differential. As a result, most pathology services in the facility will not face a reduction. However, there are some services such as bone marrow, some blood services, consultations, and apheresis procedures that are impacted. Under the current practice expense methodology, the CMS allocates the same amount of indirect costs independent of facility setting based on the assumption that physicians maintain an office-based practice, even when practicing in a facility. However, presenting evidence to challenge this assumption, CMS argues that allocating the same amount of indirect practice expense may overstate indirect costs for facility-based physicians if they are now less likely to maintain office-based practice separate from their facility practice. To correct this perceived overpayment, CMS finalized the policy to reduce a portion of the facility practice expense RVUs allocated based on work RVUs to half the amount to the non-facility expense RVUs. This is an arbitrary reduction to indirect practice expense and will likely result in unintended consequences to patient care and will incentivize consolidation. Next slide. So how does this look? So to demonstrate the significant impact of this policy on pathology, let's consider one of these codes, the CPT code 36522, photopheresis. CMS is proposing to decrease the facility practice expense RVUs for this service from 0.96 to 0.5, again, cutting almost in half. Combined with the efficiency adjustment described above, the total facility RVU for 36522 is expected to decrease from 2.86 to 2.35 in 2026. Next slide. As you recall, you may have had the opportunity to fill out a physician practice information survey for the AMA. The AMA, in partnership with Mathematicum, completed their physician practice information survey in early 2025 and submitted their results to CMS. The AMA hoped the data would be used by CMS to update cost data used in their practice expense. The data was also intended to update the MEI weights for physician work, practice expense, and professional liability insurance. Due to the limitations in the data, CMS finalized their decision to not use any of the data in the rate setting for 2026. The CAP had urged CMS not to implement the PPI practice expense per hour, PER per hour data due to serious concerns about the small specialty level sizes that introduce significant statistical uncertainty. By not implementing the PPI survey data, pathologists will avoid an estimated 8% reduction in reimbursement. However, CMS intends to work with the AMA to understand whether and how the data should be used in rate setting as part of future rulemaking. Next slide. Taking all this into consideration, this is how our non-facility reimbursements look. This provides our top pathology services, our surgical pathology services, our special stains, and immunohistochemistry. Across the board, you can see the increase is well below the 3.3% increase in the conversion factor. This, again, is primarily due to the efficiency adjustment in the work RVUs. Next slide. So if you're looking in the facility setting for the same codes, you can see that, because these services have -26 modifiers, they're not being reduced compared to the previous year, but you're still seeing a very small percent change here again because of the adjustments, largely that efficiency adjustment. So, and with that, next slide, I would like to turn this over to Dr. Bocsi, who will review the finalized changes to the quality payment program and MIPS requirements for 2026.
Thank you, Dr. McLawhon. Next slide, please. Okay, as many of you know, there have been two pathways offered under the QPP, MIPS and APMs. MIPS is a pathway for clinicians under the QPP unless the physician qualifies as a participant in an advanced alternative payment model. CMS has indicated that they want all beneficiaries in an accountable care relationship, that is value-based payment arrangements by 2030. CMS would ideally like to see traditional MIPS retired in favor of advanced alternative payment models. However, right now that's not realistic. So in the interim, they've introduced a transitional pathway between MIPS and APMs called MIPS Value Pathways, or just MVPs. So we'll spend some time discussing MVPs today because for the first time, CMS has finalized a pathology MVP that will be available in 2026. Next slide, please. Now, since the inception of the MIPS program, CMS has been steadily increasing the requirements on participants. This includes increasing the minimum number of points needed to achieve a neutral payment adjustment, as well as the percentage of cases that need to be reported to CMS. As some of you may remember, CMS has been ratcheting up the performance threshold and data completeness thresholds in the past. I'm pleased to report that for 2026, CMS will maintain both of these at their 2025 levels. And in fact, both the data completeness threshold and performance threshold remain at 75% and 75 points respectively through calendar year 2028. And this is a key advocacy win for us. Previously, CMS had proposed to raise the performance for threshold to 82 points, which would have resulted in about 46% of MIPS eligible clinicians receiving a negative payment adjustment. And we take this as an indication that CMS recognizes that rapid significant increases in the performance threshold and data completeness thresholds are impossible for clinicians to sustain. Next slide. As non-patient facing clinicians, pathologists are only scored on quality improvement activities quality and improvement activities. Quality measures continue to be the larger component, particularly for large group. And CMS defines a large group as a group with more than 15 pathologists. For large groups, quality measures constitute 85% of the total score. Scores for small practices, however, are reweighed so that quality and improvement activities are each 50% of the total score. Non-patient facing groups and individuals automatically qualify for reweighing of the promoting interoperability category, and pathologists are almost never attributed to cost measures. Cost measures are attributed based on trigger codes. And the reason that pathologists are seldom attributed to cost measures is that we simply don't build those codes. As you can see, anything below a score of 75 will qualify for a negative payment adjustment. 75 points exactly will result in no payment adjustment, and above 75 points will be a positive adjustment. As many of you are aware, 75 points is a high bar, especially for large practices. So the CAP continues to advocate for reductions in burden and for pathologists to be successful in the MIPS program. Next slide. As I alluded to earlier, for the first time in 2026, there will be MVP specific for pathology. As we mentioned last year, there are 2 pathology measures in the dermatological care MVP, but that's not enough to make it usable for pathologists. As you can see from this list, the pathology MVP is part of a broader effort by CMS to expand MVPs to cover non-patient facing specialties. So let's take a look at the pathology MVP on the next slide. So as I described previously, MVPs are intended to serve as a transition between traditional MIPS and advanced alternative payment models. They were rolled out in 2023 and have been steadily expanding since then. MVPs were intended to be and are intended to be a coherent set of activities, including both quality and cost measures, as well as an improvement activities that all focus on a single clinical topic. However, many of the elements of MVPs, including promoting interoperability category and current population health measures, do not apply to pathologists. Therefore, assuming that CMS reweighs categories appropriately, then pathology MVP actually resembles traditional MIPS quite closely. CMS has been very clear that they intend for all clinicians to eventually be in MVPs on their way to alternative payment models, and for MVPs to be the only reporting option at some point. But the timeline and details of how that happens remain unclear. They have mentioned a date of 2029 as a possibility, but that's not an official proposal yet. Next slide. So this new pathology MVP includes the pillars that were shown on that previous slide. In 2026, the MVP will include all of the publicly available pathology QPP measures, 6 of which are owned by the CAP and 1 of which is owned by the American Academy of Dermatology. As well, CMS included 3 of the CAP's proprietary QCDR measures, 1 covering bladder biopsies, 1 for biomarker testing in lung cancer, and 1 covering skin cancer diagnosis. CMS also included 4 proprietary QCDR measures from a commercial QCDR. In terms of improvement activities, the other category that pathologists are eligible for, the CMS has listed a number of improvement activities in the MVP, but honestly, only a few are really applicable for pathologists. We'll talk a bit more about improvement activities in a few slides, but with respect to the MVP, there are a limited number of improvement activities that are directly applicable to pathologists. We have submitted some new improvement activities for consideration by CMS due to the fact that relevant improvement activities have been removed from the program over the past few years. So we'll see where that goes. As I noted earlier, CMS has also included population health measures and promoting interoperability measures in the MVP. These don't apply to pathologists in single specialty practices. And in the cost category, CMS requires that all MVPs have a cost measure. So there was sure to be one in a pathology MVP. And in fact, there is one cost measure in the pathology MVP, and that's called Medicare spending per beneficiary. Now, although this measure is kind of like a general measure rather than specialty specific, and you'd think then that it might capture, broadly clinicians reporting the MVP. In fact, it won't capture most MIPS eligible pathologists because it's triggered by billing evaluation and management codes in an inpatient hospital setting. So, if you want to know if this could capture you, because the measure is already there in existence in traditional MIPS as well, and is rarely, if ever, attributed to a single specialty pathology practice, you would tend to know if you're potentially exposed to it. The CAP continues to advocate to CMS to make this pathology MVP as reasonable as possible for pathologists to use. And this would mean things like including more QCDR measures from the CAP to give practices more choices, more relevant improvement activities, and also make it more explicit that promoting interoperability and population health measures are not applicable to pathologists. Next slide. Beyond the new MVP, the CMS is keeping a lot of the MIPS program pretty much the same from the perspective of pathology, especially the basic building blocks, like I mentioned, the performance threshold, data completeness threshold, and just overall scoring policies, as well as the pathology measure set. However, there are some changes to improvement activities, as I'll describe in a few minutes. And in addition, the CMS is changing how some clinicians can participate in MVPs. However, pathologists have mostly not been participating in MVPs. So changes to MVPs, other than initial participation, really being the thing that pathologists will notice. But several of those policies are aimed specifically at multi-specialty groups. So it's likely that most pathology practices would not notice those changes. with regards to those changes, for multi-specialty groups, they tend to relate to changes to how you form subgroups. And formation of subgroups has always been complicated, and the benefits for a single specialty practice are pretty much unknown. So we won't be covering subgroup-specific policies today. Next slide. So as I mentioned, a critical aspect of MIPS is the pathology measure set, and we are glad that it is not changing. There remain 7 pathology measures available for reporting by any MIPS eligible pathology practice. CMS did not remove any measures for 2026. As always, the measure with the asterisk in the pathology measure set is the one from the American Academy of Dermatology, even though it applies primarily to pathologists. Next slide. Also, as I alluded to earlier, like the pathology measure set, something that is not changing that I'm happy to report is that CMS will maintain a favorable scoring policy that recognizes the challenges pathologists face with respect to quality measures. As you may recall, in 2025, CMS established a new policy for specialties with limited measures available, and that includes us. And under that policy, rather than assigning the subjects, a flat decile system was created for measures that previously and remain considered topped out. At the time, the CMS motivation, what they noted was that they would reevaluate each measure and its applicability for this scoring policy each year. And in 2026, this policy will continue to apply to 6 of the 7 measures. The measure it doesn't apply to, the newest measure, QPP 491, is not topped out, and it's worth 10 points inherently, but has a different set of deciles. Next slide, please. As mentioned earlier, the CMS is making some changes to the improvement activities category for 2026, including some changes that were actually finalized previously, but did not take effect until the upcoming year. Now, improvement activities is the only category other than quality that applies to pathologists in single specialty practice. Broadly speaking, the CMS is making changes in the improvement activities inventory to align with priorities of this administration, which includes introduction of a new subcategory of improvement activities called advancing health and wellness, as well as removing activities that the administration considers unnecessary. 3 of those activities were in use by some pathology practices. Take note, these activities were already suspended for 2025, meaning that they were unavailable for use this year, and that CMS is now just formally removing them for 2026. In addition, CMS is moving forward with a previously finalized policy that would affect some single specialty practices in pathology, removing IACC1 and IACC2, like you see here, which were highly used by pathologists. Like the earlier policy, this was finalized last year and now is going into effect. And hopefully practices have had time to identify alternative improvement activities if they were using either of those. There are 3 new IAs that CMS is proposing, but unfortunately they can't be used by pathologists. One covers oral health, one covers detection of cognitive impairment, and one covers patient safety and artificial intelligence. The last one, may sound promising, but it requires development of a new data collection field within the patient safety reporting system for AI attributable events. So it's pretty specific, rather narrow, and we think unlikely to apply for pathologists. However, as I also mentioned earlier, The CAP has submitted proposals for new improvement activities, which we think would be highly relevant to pathologists, and those will be considered next year and hopefully help to supplement the current IA inventory and be very useful for pathologists. Next slide, please. So the last thing I'd like to talk about in detail is a change to how participation in advanced alternative payment models is determined. CMS revived a previous proposal and incorporated feedback from stakeholders, including the College of American Pathologists, to improve upon the previous proposal. Going backwards, CMS determines who is in an advanced APM and therefore exempt from MIPS. Now, a clinician or practice does not submit anything to CMS to make this determination. The determination is done based on the practice taxpayer identification number and billing codes. Right now, determination of who is a qualifying APM participant, or we'll just say QP for short, is done at the group level and is based on billing of E&M codes. CMS indicated they heard that some practices removed specialists from their participant list if the specialists did not bill E&M code, because these specialists would not increase the number of attributable beneficiaries for the practice. And the CMS acknowledged that this seemed unfair and was looking to address it. Therefore, the proposal that they had and that they're moving forward with is to now do the qualified participant determinations at both the individual and the group level, and to expand the scope of services that would be attributed to beneficiaries, that would attribute beneficiaries to an APM practice. So CAP, along with the AMA and other groups, previously supported the idea behind this proposal because it would provide more predictable, fair and accurate picture of beneficiaries treated by the APM. At the time, we also requested more information about some certain specific situations. CMS provided some assurances and really addressed our concerns. So taken all together, we think that these policies are a net benefit as they'll prevent pathologists from being shut out of APMs and acknowledge also the important role of pathologists in team-based care. Next slide. Advancing beyond the MVPs, as I indicated, MVPs are thought to be a transition towards APMs, getting a little bit closer. And CMS has begun considering how they can, push more clinicians into APMs. As mentioned earlier, CMS hopes that different conversion factors will incentivize physicians to move into APMs. However, a major challenge is still there for many specialists, including pathologists, that there is not an APM that they can meaningfully participate in. Now, CMS has always indicated that MVPs are intended to be this transition to APMs. And, well, that sounded good, but the practical mechanism by which that would happen is just uncertain, especially for specialists. So in 2024, CMS published an RFI in the proposed rule asking for input from stakeholders on how to enable a smooth transition between MVPs and APMs. And then in the 2026 rule, as a result of that RFI, CMS has now created a new mandatory APM called the Ambulatory Specialty Model, or ASM. And participants in this model are identified as a subset of specialties, cardiology, interventional pain management, who qualify for the heart failure or low back pain episode-based cost measures in MIPS as of 2025. So even pathologists who evaluate a lot of cardiac biopsies, tests would not be included as mandatory participants in this model. And since we're not going to be included in this model, I don't want to get into too much detail, but did want to let you know that in addition to not applying to pathologists, which is a key detail of interest to this audience, it appears that this new APM is functionally an MVP, or really two MVPs that were merged together and then made mandatory by CMS. The quality measures, the cost measures in this APM are exactly the same as the ones that were in that MVP. Unlike other alternative payment models, the ambulatory specialty model also includes improvement activities and promoting interoperability. It very much builds on the existing MVPs in these areas. However, clinicians are now required to participate and report all the relevant quality measures rather than just participating voluntarily and selecting the measures they want to report on. Another key difference is that the participants in MVP are individuals. There's no group option. So like I said, it doesn't capture pathologists, but CAP is going to keep a close eye on these developments to assess which MVPs the CMS is targeting for similar conversion into APMs, because the CMS has suggested that this effort would likely be expanded in future years. Next slide. Now, the CAP, we're well aligned with AMA and really dozens of other specialty societies when it comes to protecting independent practices and the right to practice medicine as doctors see fit. As part of this high-level principle, the CMP continues to advocate for maintaining traditional MIPS while also reducing the burdens associated with MIPS reporting. The CAP is also investigating meaningful ways that pathologists in independent practice can participate in alternative ACOs and APMs without being forced to consolidate or merge with other practices to be able to do so successfully. Next slide. As part of the long-term commitment to independent pathology practice, CAP continues to develop and maintain pathology-relevant quality measures and improvement activities, and those are available in the Pathologist Quality Registry. The registry reports several mechanisms for data entry, including working with practices directly or billing companies to help maximize your score. We have excellent registry staff who will talk with your practice, work with your practice to help you navigate MIPS to maximize your scoring potential. Scoring is complicated. It gets more complicated, and it's increasingly important to understand how you can score best. Most pathology practices can score best using the Pathologist Quality Registry and the quality measures that it supports. For those of you who rely on your billing companies, we would encourage you to ask them to reach out to CAP on your behalf because the CAP's QCR measures could be an important consideration in helping you to score well. You see the email address here on the slide. Don't hesitate to reach out to better understand the availability of higher scoring measures and how to best incorporate them into your MIPS strategy. And I will now turn the presentation over to Dr. Saad.
Thank you, Dr. Bocsi. Before we go to questions, I'd just like to provide you with more information on how you can get involved specific to today's webinar and contact Congress asking them to halt the implementation of the efficiency adjustment. Next slide, please. I do invite you to scan this QR code. It will take you to our Action Center PathNet, and you can quickly send the messages to your elected officials. You just need to put in your address, and the system will identify your legislatures and automatically generate letters that you can then send. You're encouraged to customize them, put in your own stories if possible. This Action Center, I think, currently has 5 or 6 action alerts, including the efficiency factor adjustment action alert, but also on Medicare payment inflationary update, the Results Act, the PARA, the Patent Eligibility Restoration Act. We want to oppose that. And an action alert related to workforce issues, J-1 visas, etc. Next slide, please. You can also sign up to get action alerts via text message if you prefer. This makes it easier, and you can send a message directly from your phone to your legislators in just a few taps. Next slide, please. This QR code here is specific to the efficiency adjustment and, just relevant to today's webinar. If you don't take any other action today, I would encourage you to scan this QR code and send a message related to efficiency adjustment. This will go into effect on January 1, so we just have about 3 weeks to get this done. Next slide. And with that, we're going to go to questions. So I'm going to ask Ms. Yazdani to moderate the questions.
Thank you, Dr. Saad. Please type any questions you may have into the chat feature and we can get started. Okay, the first question I have here is for Dr. Bocsi. The question is the pathology MVP mandatory next year? And will it be mandatory in 2029?
Okay, so the pathology MVP is not mandatory next year, and CMS has not proposed an official date for when it would be mandatory. Now, they do continue to state that eventually MVPs will be the only way that people participate in MIPS, and CMS appears to be considering potentially 2029 as when that would happen. But there are a variety of pathology-specific considerations with reporting an MVP. So if you're thinking about it, I would say use that email address on that earlier slide, reach out to the pathologist quality registry staff and get some more specific guidance based on your particular situation.
Thank you. We did receive some questions regarding the efficiency adjustment. So this first one will be for Dr. McLawhon. Does the efficiency adjustment impact all specialties equally, or is pathology especially hard hit or singled out?
Thank you for the question. It's an important question. The efficiency adjustment doesn't impact all specialties equally. And unfortunately, pathology is one of the harder hit ones because we don't rely as much on time-based codes, except for the pathology clinical consultation codes. The winners in this efficiency adjustment is the primary care folks who do E&M services. There are other specialties that have a mix of particularly procedural specialties that are impacted, but they also do some E&M services as well, such as outpatient visits. So we are at a disadvantage compared to many other specialties because we don't use time-based services as much.
Thank you, Dr. McLawhon. And keeping with this same theme, I'll ask you another question. I know Dr. Saad did reference this somewhat, but so what is the CAP doing to stop and impact the implementation of the efficiency adjustment?
So college continues to actively engage with CMS, congressional leaders. We work with AMA, some of the other physician groups that are also negatively impacted. This is all based on flawed assumptions, lacks any kind of empirical support. The reality is modern medicine and pathology in particular, complexity has increased, not reduced pathologist workloads. We have newer technologies, emerging technologies, requiring more interpretation, verification, cross-study correlations to make our diagnosis. So again, like said by Dr. Saad, to help make CAP voices heard, particularly in the congressional area, encourage you to visit the Action Alert link mentioned earlier, send a letter to your local representative, and hopefully they'll be able to get things reversed for us.
Thank you, Dr. McLawhon. And the next question is again for Dr. Bocsi. It seems like CMS is ramping up creation of the APMs. When should I join an APM?
Okay, well, Good question. So you're right. CMS is continuing to push for all clinicians and Medicare beneficiaries to be in what they consider accountable care relationships, which includes APMs. As I mentioned, there is not a pathology-specific APM, and joining an APM can be very difficult due to the programmatic requirements for an APM. We continue to advocate with CMS and try to meet to ensure fair and meaningful representation of pathology in APMs, and we're not there yet. So it's unlikely that a single specialty pathology practice could join an APM, and honestly, we really wouldn't recommend it right now. So, again, I would again refer to the email. It's hard to give specific advice in this context. We have to really understand your particular circumstances. But right now, can't answer when, only just to sort of provide the background that CMS is moving in that direction. The time may come, but it's probably not right now.
Thank you, Dr. Bocsi. We have a question, Dr. Saad, if you'd like to answer this one. They're asking about the physician payment pool. If pathologists get more funds from CMS, then don't other specialists get less money? In your opinion, who should receive the cuts if it's not pathology?
So the person asking the question is correct. Currently, there's a pool of money and is subject to budget neutrality. And there's just, I think, a 20 or $21 million window there for adjustments. So if we exceed $21 million, then to give more money to one specialty, another specialty is going to have to get a cut. That's totally broken. I don't think anyone should receive a cut. First of all, we need to address budget neutrality. And there is a bill out there that will address it and increase that to about 50 million or so. Still, it's a drop in the bucket. The second and the most effective solution is number one, to give everyone an inflationary update. And therefore, you don't need to keep cutting one specialty so another specialty gets an increase in their fees. So I don't think anyone should receive a cut, not pathology, not primary care. Certainly primary care deserves to get more money, but it shouldn't come at the expense of other specialties. There needs to be more money put into Medicare in order for this to be a win-win situation, and for us to get an inflationary update and to address budget neutrality.
Thank you, Dr. Saad. The next question is for Dr. McLawhon, and regarding the physician fee schedule payment. Is it too early to predict what to expect in 2027?
Well, yes and no. I think it's a little too early to predict specific policies, but I think we do know that temporary nature of the funding under the One Big Beautiful Bill Act will be 3A. The conversion factor for 2027 is already subject to a 2.5% decrease unless there's further action by Congress. And given next year is a midterm election year, it's anybody's bet how Congress will react and what they will take on or not take on in an election year and what their priorities are. So, but we do know that the 2.5% will go away unless further action is taken.
Thank you, Dr. McLawhon. So the next question, I'll direct again to back to Dr. Saad, and this is back to the fee schedule slides. Noting the widening gap in Medicare pay and inflation slide at the start of the presentation, can you please explain why pathologists should be discouraged even though we are getting a positive bump up for next year?
Well, first of all, I don't want you to be discouraged. I want you to get fired up and to take action. That's the main message here today. It's correct. If we look at 2026, pathology compared to other specialties or primary care at least is only getting the 0.36% update, whereas primary care may get a much larger update. So that is on the face of it discouraging, but at least it's an update. We're not getting cut. So please don't get discouraged. However, looking forward, as Dr. McLawhon mentioned, 2.5% of the 3.3% to the conversion factor update is due to the One Big Beautiful Bill Act, or OB3, and that'll go away in 2027 unless Congress acts. So we're looking at losing in 2027 the 2.5%, and the Medicare Economic Inflationary Index is at about 2.7%. So potentially that's going to increase that delta, that gap, by another 5%. And that should get us fired up. It shouldn't get us discouraged. It should make us want to take action and take our concerns to the Hill and have them address this once and for all.
Thank you, Dr. Saad. And the next question for Dr. Bocsi. Since CAP is presenting IA recommendations to CMS in 2026, isn't it reasonable to anticipate these more pathologist-related activities to be implemented in 2027? How does CAP obtain suggestions from members regarding the improvement activities and associated documentation?
Okay. First, for the ones that we've already submitted, and is it reasonable to anticipate that they'll be implemented in 2027? I would say we would never dare to count our chickens before they're hatched. We cannot predict the whims of CMS. We meet with them, we advocate vigorously. They don't oftentimes betray all of their reasoning or motivations, and then we kind of wait to see what happens. So we have our fingers crossed. We've met with them, we've got their feedback, we've tuned them up based on that feedback. But we'll only really know once we see next year's proposed rule. As far as how we develop our proposed improvement activities, the Value-Based Programs and Healthcare Policy Committee, the subcommittee on performance, works, part of their work is developing new quality measures, developing new improvement activities. And so, we happily welcome suggestions, and you can send them to me personally. You can send them to the email address on the slide. Where it's a challenge to find ones that make it all the way across the finish line with CMS. So every year we start with kind of a basket of potential ideas and then hone them down until we can get as much as possible available for pathologists in the program.
Thank you. And now, since our time is running low, we'll ask the final question, and this also is for Dr. Bocsi. We contract with a hospital, so how do we avoid making the cost measure assigned to us if we report the MVP, since it's the hospital's measure?
Oh, okay, got it. So the good news with that Medicare spending per beneficiary measure is that it already exists. It's in the MVP, but it's also outside of the MVP and MIPS. So if you aren't getting attributed to that measure now, then you are very unlikely to get attributed to that measure through the MVP. That Medicare spending per beneficiary requires not only services at a hospital, but you have to specifically be billing E&M codes, evaluation and management services, which is uncommon for pathology groups. There are some pathology-specific considerations for the MVP. And like I said earlier, if you're thinking of dipping your toe in the water and reporting it, if it were me, I would reach out to the CAP staff through that email and have a conversation to understand a little more what you're getting into.
Thank you. And now I'll turn the program back over to Dr. Saad.
Next slide, please. Well, thank you everyone for attending today's webinar. I do urge you to stay engaged and follow CAP. Twitter, the X handle is on the screen, Twitter handle is on the screen. Follow us on Facebook. Also be sure and visit our advocacy page. It has been recently updated and improved. Please read advocacy updates. It comes to your mailbox every Tuesday afternoon, and there's a lot of good information in there. I do urge you to join PathNet, our grassroots advocacy network. And finally, I do encourage you to please stay involved. We can't do this alone. We need everyone's help. And I can't stress enough the importance of you contacting your legislators and participating in Hill Day. Please attend the PLS this spring and stay for Hill Day. You'll have an opportunity to make your voice heard. So thank you and have a good rest of your afternoon.